if you had a patient who wanted to try thiamine, either intramuscular, or you can also do it orally, or you can do it under your tongue, would you guys be okay with that, with them trying this?
What's your opinion?
So, like I said, if a patient wants to do that, they need to find a physician willing to keep testing their thiamine and make sure it doesn't go into the toxic levels. That's not something that I want to take that responsibility of.
No problem.
If they do have a physician that wants to do that, like there are these boutique thiamine clinics and
Or naturopaths.
or naturopaths, a lot of
great at this.
naturopaths will do it. That's okay. They can try that as long as it's under some type of supervision.
Thank you.
Remember, Dr. Shah mentioned that you can get toxicity from thiamine if you overdose.
Right.
You can.
You can get neuropathy from it.
So there's a test to see if the toxicity is happening.
Yeah, we just measure B1 in your blood.
Okay.
Vitamin B1, which is thiamine. We measure that.
Okay.
In fact, whenever I do, I see somebody with Parkinson's and neuropathy, and I don't know what patient has no diabetes or kidney disease. I do a B1, B6, B12, and vitamin D panel. Aside from glycosylated hemoglobin, which is for sugar. Yeah.
Okay. Thank you.
Okay,
Oh,
we got a question. Oh, from the Zoom
No, go
audience.
ahead. There's more questions in the back.
Okay. Comments on nicotine as therapy.
Nicotine. Okay, you want to take a crack at that?
So there's that rumor, or maybe it's true, that smokers are less likely to get Parkinson's. So there are studies that show that nicotine has neuroprotective effects. And those that regularly use nicotine are less likely to develop dementia and Parkinson's. I don't know. What do you think about those studies? Do you believe in them?
The answer is no. And the reason being is that I think that the reason why patients who are smokers are protected against Parkinson's is because there's you have genes that predispose you to certain tastes and certain habits and certain propensities towards substances. Like for instance, if you have a so-called sweet tooth, right? Oh, I have a sweet tooth, and your PCP is just mad as hell because you keep indulging that chocolate cake and that ice cream and all that. What can I do? It's in my genes. I have a sweet tooth. Okay, so same thing with Parkinson's. We think that there is a propensity for Parkinson's patients to have an aversion towards smoking. So therefore, if you're not smoking, right? So remember, we think it's in the beginning we thought it was protective, when in fact, have we studied nicotine for Parkinson's? Have there been studies? The answer is yes. And does it work? No. Otherwise, all of you will be on nicotine patches by now, right? We'll probably make this as a standard thing. Oh yeah, sure, Parkinson's nuance. I'll give you a nicotine patch. It will get rid of your smoking as well, right? But no, we don't do that because they tried nicotine in clinical studies. It doesn't work. Also, with too much nicotine, it can drive the tremor, increase the tremor somewhat. So I think it's more of an aversion, whereas patients, Parkinson's patients have an aversion towards nicotine, and therefore they also have simultaneously genes that predispose them to Parkinson's.
Hi, I just wanted to know what you said about the medication trihexyphenidyl.
Yes. Sorry, could you repeat that?
Trihexyphenidyl. So what are your thoughts about trihexyphenidyl? So what is the question about that?
What context you
I got it.
Oh,
Where do you prescribe it?
So trihexyphenidyl is one of the old anticholinergics. They are an old class of Parkinson drugs. Trihexyphenidyl, in my opinion, is probably the strongest anti-tremor medication out there. Trihexyphenidyl will shut down that tremor pretty well. The problem with it is it has a high side effect profile, namely being dry mouth, dry eyes, and cognitive impairment. The cholinergic comes from the cholinergic neurons. Those are the neurons that are actually responsible for cognitive thinking in the brain. And when you hit them with an anticholinergic agent, you're slowing down those brain cells. And so anticholinergics, especially as a patient gets older, causes a lot of memory problems, and it's not very well tolerated. in most patients.
Now, having said that, are there drugs outside of trihexyphenidyl that have some anticholinergic effect that we use routinely in Parkinson's? The answer is yes.
Such as amantadine.
There's amantadine, right?
But amantadine is not a pure anticholinergic
Right.
effect. So amantadine's memory impairment is not as severe as we
Correct.
would accept. with
It's not
trihexyphenidyl.
it also has some effect on the NMDA receptors, which is probably its number one property.
I have a question about carbidopa levodopa.
Mhm.
I've been taking it 3 times a day, but I figured that on a 24-hour day, and someone told me I shouldn't be taking it at night. Does it make a difference how you take your carbidopa levodopa?
Night means after dinner or before
I
sleeping?
take it now 10, 6 in the morning and 2 in the afternoon and 10 at night. And I was told I didn't need to take it at night.
Okay, we want to answer that?
So typically, if you're taking it 3 times a day, such spread apart, you'll probably have very mild symptoms that you haven't. It's not really make a big difference how you take it. This goes back to what Dr. Evidente said in the beginning of Parkinson's. You're kind of like in that mild honeymoon phase where you don't really need a lot of carb levo, right? But as the disease progresses, typically, no. I usually have patients squeeze their doses within the 12 to 16 hour waking window because that nighttime dose, you don't really need it for motor support because you're asleep. Now, that being said, there are patients that have sleep fragmentation, which is a sleep disorder in Parkinson's, in which case those patients do need to take it in the middle of the night. But unless you're having nighttime problems, typically a nighttime dose is unnecessary.
So the nighttime doses are most useful for patients that switch off at night, meaning they have off symptoms like they're rigid, they have more tremor, they have restless legs, they have pain from muscle rigidity, their balance is poor, they shuffle, and therefore when they go to the bathroom, they're at risk for falling because they're off, right? That's when the nighttime before sleeping dose makes most sense. But otherwise, I tell patients, why are you going to take levodopa before you go to bed when you're not going to be moving, right? And walking and talking and doing stuff. And then by the time you wake up, it's gone. So how did you use the levodopa? What was it for?
Right.
None. You just took a useless dose, right? There you go. Okay, other questions? Yes, there's a question over there.
Yeah, I have a question. You mentioned that the onset of cognitive decline is inevitable in Parkinson's patients.
Not inevitable.
Okay, so you can say the same or similar about the general population.
Correct.
So my question is, as with the general population, how important and effective are other lifestyle issues like weight, alcohol, smoking, exercise, mental exercise, social interaction?
Good question. Want to take a crack at that first?
So I think those things are important. Healthy lifestyles, as well as activities that stimulate your brain and keep you active, will, I believe, protect you down the road from cognitive impairment.
They found out that if you ask me, hey doc, what's the best way to slow down Parkinson's, or how's the best way to prevent me from getting demented from my Parkinson's in the future? If I were to choose just one thing, it's exercise. Okay, I'm not talking about you walking to the mailbox every day to pick up your mail. Okay, that's not exercise. Or you walking down the park around the fountain with your dog. Okay, that's not exercise either. We're talking about vigorous aerobic exercise. Your heart rate and your blood pressure has to go up by at least 20 points, and at least 20. The magic number is 20. 20 points, 20 minutes, and then do it almost every day if you could. So aerobic, vigorous exercising is the best way to slow down Parkinson's and also to slow down the cognitive issues. Now, they've talked about the so-called Mediterranean diet for Parkinson's cognitive impairment, as well as for Alzheimer's disease. I mean, there's no good studies on this. They're all epidemiological studies. In other words, if I compare those that adhere to the Mediterranean diet that have Parkinson's versus those that eat hamburgers and French fries and hot dogs as their meal every day, okay, which set of patients will most likely develop higher chance of developing dementia in the future? It's those that adhere to the junk food. those that adhere to the Mediterranean diet seems to be more, should I say, less prone to developing cognitive issues with Parkinson's. So I think the Mediterranean diet has some value, but there's no good studies on this that really prove it to be. But the more bad habits you have, the worse, I would say. Alcohol, definitely. What is that? What's your thought about alcohol? Do you give some leeway to your patients with alcohol? Do you even allow them an ounce or so?
I do, because I like to drink, so I can't be that hypocritical, right?
Right.
So, yeah, I do. I tell them that they can have an occasional alcohol with their, like with Parkinson's, if they're on medications. I tell them that social drinking is acceptable. Heavy alcohol consumption has been shown to be neurotoxic, and it does actually lead to shrinkage of certain areas of the brain depending on how many years you abused the alcohol.
Yeah, yeah. In fact, there's such a thing called alcohol-related Parkinsonism and also alcohol dementia. Okay. And so if you already have Parkinson's, you don't want to probably add insult to injury, right? Or even if you have essential tremor, and this is even more common in essential tremor patients because they found out that the best medicine for tremor is alcohol. It's not the medicine that I prescribe them or doctors shall prescribe them. They don't want to do DBS yet. They just want their booze because it works and it's cheap. And these are the patients that are more prone to neuropathy. They're more prone to alcohol dementia in the future, more prone to alcohol-related ataxia. So the part of the brain called the cerebellum here in the back shrinks considerably with chronic alcohol use. In fact, that's exactly what happens when you're drunk. The alcohol affects the cerebellum, so you're kind of wobbly and teetering side to side. It's the cerebellum. It's being shut down by alcohol, but it also degenerates with chronic alcohol abuse. So having said that, I agree. I think life is too short. I do allow my patients to have a little bit of alcohol. And in fact, and again, this is controversial, they did a study and I don't know how reliable these studies are, but this has been duplicated in more than one study that showed that if you have a little bit of alcohol, you seem to be protected against neurodegenerative disorders, including Alzheimer's disease. So the question is, how much is a little bit? So a little bit is, I would say, maybe a beer per day, or maybe 4 ounces of wine or less per day. I think it's a little bit, but anything above that, and then hard liquor, I'd say about 2 ounces or less. Okay, but again, that's controversial. That's controversial. Okay, I think we have time for just one more, right, Lynette?
Yeah, I'm going to take one from Zoom really quick too. Comments on pros and cons for rechargeable DBS versus not.
Okay.
So, with the rechargeable versus non-rechargeable, yes, if you really need a high voltage stimulator settings, the rechargeable is convenient because then you don't have to replace the batteries every couple years. But the battery replacement is not really that big of a deal.
Not a big deal, but some patients don't want any surgeries every
done.
4 or 5 years.
Correct.
That's
So-
the non-rechargeable. That's against the 15 years.
Yeah.
But at the same time, if you're demented though, and if you don't have a good caregiver, or if your caregiver works,
And you forget to charge
and
it,
you forget to charge it, right?
then it's going to cause issues.
Yeah. Or if you travel a lot and you forget to bring your charger,
Mhm.
you're screwed, right?
Yep.
Yeah.
Once you go off,
Yeah.
you got to have a rep coming in
It's
and
like
back on.
it's like you can borrow somebody's charger in the cruise, right?
Yeah, you got to look for.
This-
You got to look for.
Yeah, yeah,
You got to make sure it's the right platform too.
yeah, exactly.
They might have
Oh,
the same
oh,
tune. You got to Medtronic.
you know, back in the day when it was just Medtronic, it was so easy. I put the programmer of Medtronic in my little bag, and they called me to the hospital. Sure, I'll be there. But now there's like three platforms, and oh my God, it's like I gave up. I'm not gonna bring this thing anywhere. And so, okay, I'm gonna ask. I'm gonna ask for the next 2 or 3 minutes. One of our patients to give you a patient testimonial. We talked about this in the past. I want a patient of mine to give a patient testimonial, encouraging words to you about his journey with Parkinson's and how he conquered Parkinson's. I'm going to make you welcome Michael Kurla. Okay, Michael, grab the mic. Please stand over here.
Oh
Stand over
boy, on the front?
here. Yeah. That's
Oh, oh, here we go. Yeah, this is crazy. It's the first time I remember doing this. So, 18 years ago, in my mid 30s, I was diagnosed with early onset Parkinson's. My roller coaster ride of a life since my diagnosis includes pretty much, I was on pretty much being on every Parkinson's medication possible, as mentioned today. And some of the powerful side effects that affected me personally were hypersexuality, impulsive control disorder, and much more, contributing to an abrupt divorce after a 23-year marriage, losing communication and respect for my 2 adult children, leaving me with very, very little support, that I had suicidal thoughts, trying to drown myself numerous times 3 years ago. It was my faith and resilience to fight Parkinson's that pulled me through some very, very difficult circumstances. I knew I had to either make major changes in my life, and that included finally humbling myself, taking a webinar on DBS. They claimed they would reduce my medications approximately 30 to 40% in my case. So finally, in May of 2023, I gave in to DBS. Deep brain stimulation surgery after an extensive heart-to-heart I had with myself and my neurosurgeon, Dr. Kasikas, back in Pennsylvania at Penn Medicine. I had a choice to make on the stimulator, and I made the right one for myself, Medtronics. I had the non-rechargeable one. So it just anyway, transitioning to Mesa, Arizona, July 30th, 2023 with my 2 dogs, and I only knew one family at that time, was and still very challenging because I only had the initial programming completed. And until I found Dr. Evidente, I had to travel back and forth from Arizona to Pennsylvania to get adjusted. So with the help from one of my Medtronic support team, Paul Sherlock, who was there for me pre-DBS, post-DBS, and helped me find Dr. Evidente. It has not even been a year since my DBS was completed on May 22nd, 2023, but I've gone from, Dr. Evidente says a whopping dose, 16 of the big blues I had was on, 16 245s per day. Whopping, okay, so I thought if he would say that. But that was per day pre-surgery to being, now I'm off of Rytary completely. Zero, plus 75% down on Pemapaxil. In addition to the medication reduction, I recently went back to work, and I'm planning on running in the Pat Tillman race next month on my birthday with my Medtronic shirt on. In closing, for my in closing, for me personally, every day I'm here is a blessing. And my motto is not outworked. Whether I'm in the gym, working, or whatever I do that day, no one person is going to outwork me. Thank you, Dr. Evidente.